First of all, I would like to thank Professor Jose Castillo and Professor Manel Pumar for the kind invitation to this beautiful city. Muchas gracias. My English is bad, but my Spanish is worse. And the thing is, because I have been married 30 years with a Spanish-speaking woman, she's from Colombia, and my both boys speak perfectly Spanish, I decided, you know what, to stay out of the trouble and not learn it. So the point is, I have to speak, unfortunately, today in English. I'm very sorry, because probably I'm the only one with payroll. The second thing is, I had 2 talks to present, and due to the time restriction, we have reduced it to 1 talk. So I will start summarizing a few of our parts and put both talks in one. The first talk was on cone beam CT in large vessel occlusion, and we have introduced some new things and aspects that we are working with Philips in Best on. And I will give you a little bit glimpses where that research is going. And then the second paper is more on the clinical side. So please be patient with me if it goes a little bit too fast. These are my consulting arrangements. Some of the work has been supported, is being supported by NIH, and others by industry. So in the United States, we are trying to introduce more the collaborative effort between the industry and the government, NIH. And you see one of the benefits like the Pfizer, Moderna vaccine, or AstraZeneca or J&J. J&J, in fact, was developed at Beth Israel Health with the help of Johnson & Johnson and the government. So you have heard all these talks before. The flat panel detector, or we call it the cone beam CT in the angiography suite, has reached a multi-purpose task. There is a study going on, we trust, and I hope that Raul Noguera yesterday talked about that. We are developing the CT scanner as a place that does the intervention, so angiography intervention, but serves also like a cockpit to answer physiological things. As you see here, this is from Vito Pereira's place with MAFA, cone beam CT, almost histological-like cross-sections using the cone beam CT. So we are trying to do not only static images, dynamic images, but we want to study all the physiology. And then these are the various flavors of the same technology. You see the 3D RA by changing the Hounsfield units and also the geometry of the acquisition. You have the expert CT that works at a different Hounsfield units, and then you have the Vaso CT. All these can be done for our stroke patients, for our patients who undergo vascular work. Here, Vaso CT for ischemic stroke with large vessel occlusion. And this was proposed several decades ago. How can we manage the workflow by using this simplified version of an intervention CT scanners? Our group was interested in 2 things, and that's where the focus is on the current research. The site of occlusion and characterization of the occlusion. And you heard from previous speaker, Jeremy, that was very nicely. And Fernando, thanks for the discussion. I understood a little bit. So we want to know what is going on in that segment where we operate. Right now, it's a lot of guessing. I think OCT will be helpful, but OCT has the limitation that you need flow, or at least you need a semi-open vasculature to flush that area with water so you can acquire data set. But we are dealing in this situation with a clot or an occluded vessel. Not completely, but often completely. So we need to define the lesion and also see beyond the lesion. Often when we wire, we go into a small branch or we are in the subarachnoid space, and we do more harm than benefit. And the second thing is, in our whole world, we want to characterize what were you doing with the clot? What kind of a clot is it? So these were the 2 questions we had. This is, for example, a case of a M2 occlusion. You see all these things. And this is the Vaso CT, and I will run the video clip, and you already discern, I can't see it from here well. You already discern the clot inside that. But with the Vaso CT, when you do a delay, you will see the contrast going from the back door, and that serves for your roadmap. So you could use the Vaso CT, and we have the capability at our place where we use the Vaso CT you go through the clot, you will know now where are you passing without rupturing that. Can we play the video? I don't know, should I press forward? This is a thin slice of video. You see here the clot sitting. È possibile advance the video? Sí. Gracias. So what you see is you see the ultrastructure and you will see also the occlusion side. That's one thing. Now, if there's a plaque underlying or dissection like we heard before, we can characterize that as well as with a vaso-CT. This is a occluding with plaque, and you can see sometimes calcification at a higher resolution. So that becomes your roadmap in your angio suite. That's one interesting aspect. Now, the second one, which is more exciting, is when you intervene or you think of bringing your patient directly into the cath lab and the patient had a CT angiography somewhere else, so drip and ship, you get this CT scan and you look at the films and you don't know, is that contrast or is that blood? It's a very important aspect. Also intraoperatively, when you do something, you want to know, is that blood or is that contrast? So how do you differentiate that? Well, down there you are MR. Obviously with the portable MR scanners, Hyperfine, and the other companies that are coming with a portable MR scanner for the angiography suite, we will have some advancement. But I would propose something new that we are working with Philips on, and that is spectral CT. Philips is working on a spectral CT scanner based on the cone beam technology. So you will have the sandwich cone beam in the operating room. And I think that's an elegant solution, and I want to show you the difference. So this is your regular state-of-the-art flat panel angio, and you don't know, is that a bleeding or not yet? This is after intervention. We do a normal spiral CT, and you see here the same structure like in the cone beam CT, and then you do without contrast, the same different acquisition, and this is not a blood. This was all contrast. So what you are doing now intraoperatively is you are basically removing the contrast element and discerning. And this has an impact. You reverse the TPA. You may need to go back and see where the leakage is. You seal the leakage with a coil or with glue, whatever you do. So this will be a workhouse intraoperatively. So you have dual energy scanners integrated in the cone beam CT. And this will be very soon available. The last point is we were interested in characterization of the clot. As some of you may have followed our work in the past where we have retrieved clots from the body and we did some analysis, biomechanical strain stress analysis with all these clots, and we found differences in the clots, and these studies were based for a lot of stent retrievers you currently are looking at. This is, for example, a calcium apatite material, calcified material, has a different biomechanics as compared to cholesterol-rich material or as compared with a red clot-rich, erythrocyte-rich material, which has completely different biomechanics and maybe also subjected to a different treatment. Right now, we aspirate. If it doesn't work, we switch to clot remover. If that doesn't work, we drop a stent. But the question is, working with machine learning or artificial intelligence, we want to collect as many data as possible to increase the predictive value of the success. That's the final goal, success for highest efficacy. Now let me show you what we have been doing now. We acquired these clots that we took out in vivo and vitro. We are right now at vitro studies. We had acquired image analysis by using cone beam spectral CT scanners, and I want to run you some of our data here. This is from a patient, a fibrin-rich clot, and you see the conventional CT scanner, the absorption spectra here at a Hounsfield anywhere from 26 all the way to 96. So in the ballpark of a mean, you see the standard deviation, in the ballpark of a mean of 26 Hounsfield units, 50, I think, 50 around. When you do it without the contrast, so you remove with the spectral CT scanner any contrast elements, because when you do an angiography, of course, some of the clots will aspire, soak in the clot, contrast. So you have to remove the contrast, and when you run then the whole spectral analysis, it will give you the somewhere at a mean of 50. Now, when you go to a erythro-rich clot, you see the Hounsfield units goes up, of course, because of the rich erythrocyte content. And you can do mixed clots, you can do calcium clots, on and on and on. And you can create your spectra. And here, of course, without contrast, and the conventional CT gives you Hounsfield units of about 200. So there's a difference between a fibrin-rich clot and erythrocyte-rich clot. There's a difference between calcified clot. Where does it help us? It helps us then, in summary, I think. With the cone beam CT, we can better characterize where the occlusion side is, and it will be helpful for studying, using roadmaps, safe removal of the clot. It will also helpful by introducing dual energy cone beam CT scanners to differentiate hemorrhage from contrast, and it will help us to characterize the clot. And that's where we are standing right now, and we hope next year to give you some clinical data. That was the first talk. Should I move to the next one? I know we're running, so thanks. Any questions to this one? And I will move forward. Any questions? I know it was fast, but I have to keep up. Any questions? Okay, so the next talk is more clinically relevant, flow diverter in acute ischemic stroke. What is the role of flow diverter? As you know, in the United States, the Streamline, which is the larger flow diverters, was approved in 2018. And these are my... So with the approval and with the pipeline involved, the indication for the flow diverter has increased. We are moving now to ruptured aneurysm in the anterior posterior circulation. We are moving to internal carotid artery, the cervical part, and then more distally with the recent introduction of the smaller devices. So an exciting field how to repair it. So first of all, observation a while ago was when we have these structures, this was a patient with a subarachnoid hemorrhage, and we place a flow diverter. I generally anchor the proximal part of the flow diverter with a carotid stent because our experience has been that the flow diverter don't have radial force, so the patient moves around and you get intimal hyperplasia, or they try to move and basically pull up. So this is a patient where we placed a 3x20 streamline and a precise flow diverter, and this is 6 months follow-up and a year follow-up. So the healing is amazing. We have done now probably 20 or 30 of those patients, and the risk is almost 0%. It's not more than an angiography risk in this patient population. This is another patient that has a ruptured aneurysm of the neck, and there was a lot of disease segment here, and they had coiled it at Mass General Hospital, and the patient was running with this, and we decided to place a flow diverter, and this is 6 months follow-up. And if you look closer, there's a thin carpet of endothelium, and that's something where I think Dimitri's OCT technology will be very helpful. Now, the second observation we had, these arteries are big, so we wanted to see whether with the streamline we can cover large diameter vessel. This is a case where we observed two phenomena: healing under anticoagulation and the device sizing. This artery was 7.5 millimeters, so we used the streamline, which goes up to 6, and then we used 2 neuroform stent in barrel technique and further opened up to anchor the device. And because of the braid angle of the device, it opens up further out, reaching the 7.5. And the patient was put on Eliquis, so anticoagulation, and dual antiplatelet therapy, and we have tapered him down to 2.5 Eliquis. And if you look at the follow-up films here, there's a significant reduction of the aneurysm itself over the last years. And the interesting thing is that the perforators in this segment remain open. And we are finding also something very interesting, that the perforators run along the basilar artery, so there's a regeneration of perforators. So the sizing was important. And then the third question we had for ourselves was, in this high flow environment, will dissection heal or not? And we placed, for example, in this case was a dissection with a stroke, intracranial stroke. We placed a device, and this is 6 months follow-up where the artery have repaired. Simple procedure. So we started this in 2018, and this is one of our first patients, a 35, a generally young patient with a basilar occlusion and a dissection of the left vertebral artery. And we went and did the thrombectomy from the right side, and then we placed a flow diverter on the right side. And this was the condition, I think a month later, that we had a pseudoaneurysm formation. We placed the flow diverter here, and this is 6 months study on the lady, and then repair of the artery. Another very interesting case where we had a right MCA occlusion, and when you look closer here, there's something going on here next to the artery that's closed. And when we look at the left side, there's a tortuosity. So the gentleman has some redundancy of the artery at the skull base level, and he had an occluded right internal carotid artery with this clot here. So how do you address it? When you have the information on the left side and the CT helps you, there has to be a dissection with a very strong loop. So how do you keep it open? We used to use neuroform stent. We used to do everything, but the problem is once you place these non-braided stents, it's very difficult to go back because they do fish scaling, they kink, you don't cover the whole dissection. So what we have found out is that with the flow diverters, to address that is fairly easy. And this is how we did it. We went with the wire through it, and we used multiple telescoping flow diverters, and this is how these segments look, ugly, and then we go with our catheters all the way up and could address that. There's some vasospasm here, and when you wait long enough, that will go away. So in total, over the last few years, the yellows are all acute ischemic events, so where we use thrombectomy and flow diversion. And the interesting thing is that these patients have done very well. And I did a little bit of analysis. If you look at MRS, except this one patient who has MRS, I think 2 here, a young guy with 38 with a dissection, these patients tend to do very well. The reason I think is that they are young people. That's one of the reasons. I think they come very fast, are admitted for revascularization very early because they're either at work and they're found by the family members at home, by friends. So the ED to revascularization time is very short. And how do we deal with these patients? Because they have an occlusion. We generally use a bolus of integralin, and then we give them 12-hour drip, do a CT scan to rule out any hemorrhage, and then we switch to Brilinta 60 milligrams BID. In the internal carotid artery, we had a patient where we put only on aspirin. We don't have IV aspirin like in Europe, other places. Otherwise, I think the aspirin may be good enough. Another case here of a dissection of the carotid here with subsequent ICA occlusion here, aspiration first pass, and then we place the flow diverter, reconstruct the whole area. Now more recently we have introduced the balloon guide catheter, so we make sure that the balloon is inflated before we pass through the lesion and place the flow diverter because we don't want thromboembolic problems distally, and then we go after the clot and remove the clot here. Another case, younger man, big dissection with a clot here, placement of a flow diverter, and then removal of the intracranial clot. This is the flow diverter placement. And like I said, it's very simply done. It's very easy. And this is the first pass. This is 6 months follow-up with reconstitution of the dissected area. In summary, I think flow diverter placement prior to thrombectomy with flow arrest proximally is a very feasible approach to dissections of the skull base of the internal carotid artery with subsequent large vessel occlusion. In our center with small series, single antiplatelet agents have been sufficient. In the early phase, we start with eptifibatide and then convert after the first CT scan that there's no hemorrhage, convert to single antiplatelet with Brilinta. I think the high efficacy and excellent clinical outcome with the low peri-procedure morbidity has to do with the age of the patient population and the needle to revascularization time. And what we have found out in this population with dissection, the ICA heals very well, so you can eliminate within 6 months dual antiplatelet therapy. With that said, thank you very much.